Our third leaders debate of the day. Our panel will be covering decontamination and particularly working to share some of the learning that we've picked up over the past 18 months, where we've all needed to work to a gold standard of decontamination in everything we do. Not that for most of the people here today, that isn't true all of the time. Joining me to discuss this are Linda Swanson, Director of Nursing Infection Control at Salford Royal NHS Foundation Trust, Dr. Katie Laird, Head of the Infectious Disease Research Group at Montfort University, and Mark Campbell, Decontamination Service Manager for NHS Wales. Our panellists, as you can see from their titles, are perfectly placed to share some of the best practice and experiences themselves and colleagues have had during the pandemic. So if you'd like to ask a question, which I'm so glad you've asked lots already today, we've got that live Q&A functionality open during the panel, so feel free to use it. The team at NHE are working behind the scenes to take in your questions and pass them across to me so I can ask as many as possible. And if you see my eyes looking across to the right-hand side of the screen, that is actually what I'm doing, monitoring the questions. So welcome to our panellists. Oh, okay, no worries. Well, we're going to start off with Katie. We're having a few gremlins in the system. Hi, Katie, how are you?
Hi, fine, thanks. You?
I'm very well indeed, thank you. To start off with, Katie, well, it's just me and you, if that's okay, is to hear in layman's terms about the research that you've been doing centred on the prevention of transmission of healthcare acquired infections, including the development of antimicrobials. Tell me about what you've been up to.
Been busy in the last year or so.
Sounds like you've been busy, yes. Tell me in layman's terms if you can, so I understand.
Yeah, much of my research focuses on healthcare textiles and the role they play in the transmission of microbes. So prior to the pandemic starting, most of the research was focused on bacteria, so how long it survives on a range of textiles that are used in the healthcare environment, and then looking at both domestic and industrial washing to remove those microbes, and what processes are best in for the decontamination of textiles used within that healthcare environment. But obviously the focus slightly changed when the pandemic started, and I worked with a virologist, Maitreyi Shivkumar at DMU, and we developed a model coronavirus for SARS-CoV-2. And so then we applied all of the research and knowledge we have from bacteria to the virus to understand the survival of the virus on those textiles, how to decontaminate them, and the potential for cross-contamination to other surfaces.
Just explain, just because I'm not in the medical world, and I know it'll make sense to our audience, I'm sure, but in your world, what do we class as textiles?
So as in textiles, we're talking about things like the nurses' uniforms, which are domestically washed, which obviously brought some concerns to the forefront during the pandemic. And then we're talking about things like scrubs, bed sheets, which are industrially laundered. And then you have things like the curtains, again, they're industrially laundered. So the types of textiles you'd sort of see in and around the hospital environment, really.
And what did the research show? What were the key findings?
The findings showed, when we were looking about bacteria, that on polyester, cotton, and polycotton, they're the main types of textiles used within the healthcare environment, that the bacteria was able to survive for up to 21 days. And when washed at 40 degrees, which is actually below what the Department of Health recommends at 60 degrees in a domestic washing machine, these bacteria were able to survive and cross-contaminate sterile items within the wash. We did do a survey of nurses. The initial survey was quite small, about 250 nurses, to understand how they were washing their uniforms. And this was prior to the pandemic. 44% of the nurses were washing at 40 degrees and with other items of clothing, which suggests there could be a risk of bacteria surviving on uniforms. And there has been a lot of research, not just by myself, but by other researchers in the field, that have shown that bacteria is able to survive on textiles. So when we're looking at decontamination, if nurses follow the guidance of 60 degrees, yes, it does decontaminate. But if that isn't stuck to, there is a risk, albeit maybe small, of potentially cross-contaminating with uniforms. But I think the key thing is that we found that it transfers to other surfaces when we were looking at coronavirus. So the fact that the nurses are potentially taking their uniforms into their cars, into the domestic environment, we don't know what the risk of that is yet. The guidance did change so that it was more highlighted that nurses change on site. And we did a large survey. I think we had 1,280 responses. This is still to be published. It's under review at the moment. And the nurses felt confident in following the guidelines, which was really good. However, under the pandemic circumstances, they would prefer that their employers laundered their uniforms for them, and that in order to follow the guidance, they needed much more changing facilities available to them. So that was interesting. That was sort of, we looked at the attitudes in the nurses alongside the survival of the coronavirus. And we saw that it survived on polyester for up to 72 hours. We found the more absorbent things like cotton, it was less time, 24 hours, but it could transfer to plastic and other textile surfaces.
Wow, that's a great explanation for holding the fort. I'm going to ask Linda about nurses and uniforms and stuff in a minute, but now that Linda's joined us, it'd be just really nice to start off, Linda, with a snapshot really of what life's been like for you as Director of Nursing Infection Control through the pandemic and the last 18 months.
Wow, Helen, what a question. Where do I start? It has been, it's for most of us in this field of expertise. We became aware of the coronavirus back in December 2019, and we're watching all over the Christmas period while everybody was celebrating, just to see what impact it would have. And obviously hoping that it didn't have the impact. I don't think any of us could have been prepared for actually what happened over the next few months. So I can recall being called as a room when the first case hit the UK shores, and what that feeling was like, sitting across the table from some of my peers who were absolute experts in infectious diseases. And we just looked at each other and we were like, oh my, you know, this is going to be big. The scale of it, however, it has been an immense journey. It really has. But I think throughout this, what it has done, you know, we obviously, you know, the coronavirus has not been good for the population. But actually, in terms of infection prevention and control, we've learned an awful lot. And there have been some benefits. So it's allowed us to break down barriers that previously existed within the NHS and across multiple care sectors. So actually, there has actually been some really good outcomes from this for us. So yes, it's been one heck of a ride. We're still not through it yet, but there's definite light on the horizon. As we call it in the business, green shoots, and it definitely feels hopeful. So with the rollout of the vaccination program, things are really starting to look up. So yes, we're all getting excited along with the rest of the...
That normal life is sort of slowly resuming, and hopefully we're in a better place now than we were to deal with anything like this in the future. But before you joined us, Linda, we were just talking to Katie about the focus of her research that she's been doing on, you know, the role of healthcare textiles as fomites, if you like, or spreading disease. And we were talking about nurses' uniforms and how to wash them, and how nursing staff felt about, you know, washing their own uniforms, should they have been washed in, you know, at hospitals, etc. How did your staff deal with that kind of thing, and what was their attitude, and, you know, potentially, you know, the virus being, you know, on the fabrics that they wear?
So at the beginning of the pandemic, obviously we didn't know very much about it. So there was heightened anxiety about that. We put in additional changing facilities for our nursing staff. Literally, if you like, shipping containers shipped on site with facilities for showering, changing, and staff were provided with scrubs so that they could change at work and the uniforms were laundered at work. As new and emerging evidence has come through, obviously we've realised how important, and always have, laundering of healthcare linen is. But it's about putting safe processes in place to enable staff to change when they come into work, and not that just being on the toilet floor in the corner of a room, which has often been the case. So proper changing facilities and enabling staff to do the right thing. What we call in the kind of QI industry, forcing functions. So providing staff with the facilities makes it much easier for them to do the right thing, and actually lessens their anxiety about taking their family.
We've got lots of questions coming in about that subject. Katie, I think we could whiz through a few of these with you. Cheryl says, would you additionally advocate tumble drying and ironing to further reduce the bioburden?
Yes, would. Yeah. My research and other research has shown that to be the case. And as I mentioned with the coronavirus, if you wash it even at 40 degrees with detergent, you are able to remove the virus from the textile. The risk is that bit from leaving the hospital to it getting into the washing machine. And as Linda's rightly said, having changing facilities that are accessible and changing out the uniform on site limits both the anxiety, but also that potential for cross-contamination, because once it's in the washing machine, you are able to remove the coronavirus.
Amy makes a comment. She says, wow, eye-opening data. So glad to be wearing scrubs in endoscopy, laundered by the Trust. And also, we've got Amber says, dentistry have been required to launder our own uniforms at higher temperatures for a long time, and also not allowed to wear our uniforms outside of practice. Why do hospitals seem to be behind on this aspect?
I don't know why they are. I can't answer that question. That's not something I can answer. But I think when we look at the EU, all their hospitals launder industrially. So I think it's the UK, Republic of Ireland, and certain parts of the US that domestically launder. So there is differences in practice globally as well.
I'm sure there's different practices everywhere. And Christine says, how likely is the virus to come off textiles when touched?
What we showed was cross-contamination to from polyester to plastic and to other textiles. So we didn't do skin. So I can't comment precisely on that, but there is a chance it could, like with any surface, but the more absorbent the surface, the less likely that is. So the very absorbent cottons, we've done some work on leathers, it's not as easily transferred. But I think the other thing we need to remember with coronavirus is the main transmission route is respiratory, and that evidence has come out more and more. So it's about, there is a role for fomite transmission. And I think Linda mentioned this, it's about limiting those risks and allowing to take the nurses to be able to take the right processes and procedures to limit that risk.
I thought, Linda, that I don't know whether you heard Dr. Ben Cantor on his pre-recorded keynote speech a few minutes ago, but one thing he was saying that he thought that we need to rethink modern PPE because communication is such a fundamental part. And I just wondered how communication and, went with you and how you managed to handle it to make sure that while your, teams were covered in all the sort of equipment and protective gear, the communication was still there.
Yeah, so it's a really, because as you can imagine, seeing healthcare workers coming towards you dressed in effectively spacesuits can actually be really scary for people. So it was actually thinking about different strategies, and we've used this throughout other pandemics, perhaps not in this country, but if we take into account, for example, Ebola, highly transmissible, very poor out contact with it. And actually, nurses and doctors came up with their own novel solutions. And some of these were simple, writing their name on their coverall and saying who they were. So, my name's things like that. But communication as well, looking at people who've got impairments in communication. So the wearing of face masks, excuse me, obviously impedes who have a. So we've been working with key stakeholders to look at developing face masks which are clear, which can allow that communication. It is actually really important, and it's actually vital to have a kind of a multitude of strategies to try and address any communication challenges you might face. A lot of that as well is in organisations' campaigns about communication. So, for example, ours is, there is always a smile behind the mask. You might not see it, but it's always there.
And I gather that you've been using some new and rather novel methods of decontamination in your organisation, Linda.
We're always keen on decontamination, and prior to the pandemic, we were trialling light decontamination, and I'm sure a lot of people on this forum will have perhaps tried it themselves. And it was always a science that was building. Actually, it needed more evidence base behind it, but actually sometimes you dribble it and go with it, and actually work with the, and there may not always be a strong evidence base, and we've learned this throughout coronavirus. You've got to be brave enough to try new things. So we did introduce mobile UVC decontamination units, and they were very, very popular. First of all, they were proven to be effective against a range of organisms, but actually they had another benefit, an unintended benefit, and that is that members of the public and staff actively saw you decontaminating areas, and they could be used on a rolling program of decontamination. So not just when you have a problem, but to keep your hospital clean all the time. We took that a stage further during the pandemic, because we realized that in order to stop blockages and potential crowding within emergency departments, we needed an effective decontamination. We had to eliminate the time required to achieve that. So, for example, if you imagine a busy emergency department, room, resus area, a high-risk area, once a patient's been of evidence about how long it took to get that room cleaned. So the room has to have a manual clean. You can't decontaminate without manually cleaning first to remove the organic debris. So once that had happened, the teams then had to call for a specialist to bring the machinery to them, which put in another 30 to 40 minutes time delay in getting that room cleaned and getting another patient in. So we fitted the UV light connect system and emergency departments, which meant once that manual cleaner, the trained staff could close the room, and about 10 to 15 minutes later it had been decontaminated. That obviously operationally means that we can use our hospitals more effectively, and it affects patient flow through the departments. Another novel method that we used was, obviously, ventilation is really key in COVID, and as emerging evidence has come through, we've realised how important that is. But actually, ventilation also plays a role in decontamination, so it helps to clean the air. So we did trials within some of our wards, and we used smoke, we used CO2 detection to see how effectively we could clean the air at the time, and then introduce some HEPA filtration units to make this happen.
Gosh, it sounds like you've been on such a learning journey. It's great to hear some of the things you've been doing. And Katie, I'm fascinated to read, when I was reading a bit of your background, that you're a founder of a Germs Journey, which is educational resources teaching young children about health hygiene globally. I mean, I have two children. One of them's just turned 12. And, listening to the way my children talk now and the language that they're using sort of post-pandemic, is interesting, and their awareness of hygiene and cleanliness. Just tell us a bit about that project, Katie, because it's so important, isn't it, to make sure that our youngsters are part of this journey too.
I strongly believe in teaching. Germs Journey is aimed at sort of 3 to 7 year olds. The understanding habits of good hand hygiene, not just go and wash your hands while you're doing it. And the Germs Journey has been a wonderful journey for me. And it's something I'm very passionate about. We've developed or co-created books with stakeholders around the world. We've got books, we've got we've done significant work in schools, and we are actually moving into paediatric wards, hopefully, later on in the year. And it's all free at the point of access. So we transfer books into, we've worked in the Penny and Sierra Leone, translate the books, not only written translation, but also so that the images are relevant and mean something to the children that are using them. We've done an awful lot of research that's shown that we can change behaviour. We've got little, and also workshops we do in school, so we can increase the areas that the children are washing their hands. We've increased understanding in children, which is long term. We go back after a month by, I think it's up to between 70 and 80%. And most importantly, when we were in India, we went back 2 years later, and there have been reported reductions in children within those areas, because they've been using the books and teaching their grandparents and their parents all about hand.
That sounds a fantastic project, Katie. Your microphone's breaking up a little bit, so I'll move back to Linda, if I may, Linda. Don't worry, no, it's not your fault. It's, you know, we're all on a big learning curve with virtual conferences too. How important is it, Linda, to make sure that IPC is evidence-based and that we are brave enough, if you like, to change our approaches when new evidence emerges?
It's so important, Helen, and throughout the pandemic, as you say, we've all been on an incredible learning journey. And actually, we have to be brave enough to change our approaches as new and emergent evidence comes through. I like to think of it a little bit like driving a car. Driving, you want to get to the destination, but actually it's about constant adjustment, a little bit this way, a little bit that way, always paying attention and always prepared to change to keep people safe.
Richard's got a question for you, Katie. May I ask, from a study point of view, which endpoints do you feel were the most valuable when looking at reducing bioburden on surfaces?
So when we were looking, so do we mean the surface of the textiles or surfaces in general there?
I think do both, if that's okay, because he hasn't specified.
I think with the textiles, when we're looking at the bioburden, we were looking at the key points and when best decontamination, because when items are industrially laundered, so your bed sheets, your scrubs, they have a dirty and clean area as soon as those items go into those environments. And that isn't, we're not able to do that so much with the home environment. So it was looking at the bioburden at the point at which it could transfer to other surfaces. We then looked at it during after the wash, which we've got a number of factors in there, and we broke that down. So we've got agitation, dilution, temperature, and detergent, and we tried to unpick that, what was having the most effect and what had the most effect on bioburden. And with the bacteria, it's generally a combination of temperature and detergent. With the virus, it's actually either temperature or detergent. You can use one without the other almost and still have the same effect. When we're looking at surfaces, the bioburden, really, I think this comes a bit back to the point of you need to clean before you disinfect that Linda made. It's really important that you evaluate the interfering substances that are potentially there, because they can significantly reduce the effect of any disinfection used.
Fantastic. Just squeeze a quick one in from Donna. Probably to you, Linda. On the National Review of Uniforms, and how much has IPC been involved in this? Is that something you feel you can comment on?
Yeah, so we in the development of the national uniform policy. I believe that's due out early next year, and we are looking at obviously different types of uniform for different settings, but also maybe some more of the uniforms which people find more comfortable at the moment and tend to go towards, so such as scrubs. The public's perception when they see somebody wearing scrubs, you know, outside of the healthcare facility, is that they've just come out of an operating theatre, and actually some scrubs are used for multiple other areas, and it's important that we professionalise them so that, you know, so that we can have that clear communication with the public. But absolutely, we want to get to a point where we're making it easy for people not to wear uniforms outside of that. That can obviously be difficult because we have community staff delivering care within the community, and sometimes part of that will be, for example, taking a patient to a supermarket to assist them to do their shopping. So there's going to have to be a lot of communication around this to support it, but we welcome it, and absolutely we have been involved in it.
Oh, well, listen, thanks to both of you. It's a shame we didn't get Mark, but Linda and Katie, it's been brilliant chatting to you both. And I'm sure our audience have found what you've said really insightful and valuable. So from there, we're going to move on to an exciting keynote speaker, Professor Martin Marshall, Chair of the Royal College of General Practitioners, or RCGP. General practice has remained open throughout the pandemic and has had to overcome a number of challenges in tackling and controlling infection during that time, both to protect patients and the staff delivering the care. So, Martin, I'm going to hand over the virtual stage to you.
Helen, thanks very much indeed, and thanks for the invitation to join you today. So yes, I'm Martin Marshall. I'm Chair of the Royal College of General Practitioners. I'm a GP in Newham in East London and also an academic at UCL. So I'm going to be talking about the impact of the pandemic on general practice, both the immediate crisis impact and the potential future impact as well. Looking at it through the lens of infection control, but actually looking much more broadly than that as well. I've got 15 minutes, I understand. If you've got any questions or comments, please put them into the Q&A function. I think that's where you put them. Helen will let you know about that. And if we have an opportunity to address them, I will do my utmost. So let's go back to January, February, early March 2020, last year. Feels like forever ago. And explore what happened. So when suddenly the seriousness of the COVID infection became clear, government did what government often do, which is focus on hospitals first of all. And I guess that was because we saw some terrible stories of what was happening in Italy, where Italian hospitals were being overrun, particularly in the north of the country. And politicians in particular, but civil servants as well, were greatly worried that was going to happen in the NHS. So the initial focus was on hospitals, but very quickly they realised that general practice was going to be important. General practice is where 90% of patient contacts with the NHS take place. And what they decided, I think probably rightly, was that general practice needed protecting from the pandemic so that it could carry on as much business as usual, much non-COVID health issues as was possible. And that's why they introduced NHS 111 as the first port of call for any people in community settings who had queries or problems that could be related to COVID. And they also introduced hot COVID centres into community centres to deal with more acute problems. I think those were interventions that worked pretty well. It kept most patients, at least initially, out of general practice, which is important, partly so that patients weren't infecting each other, and also so that staff weren't infected, and that could cause the system to collapse. It didn't work completely as you'd expect. Most patients are used to talking to their practices about health problems, so quite a few people were still phoning up in order to address COVID problems. But by and large, it seemed to work really well. The infection risk of COVID was recognised very quickly, and that's why guidance from the centre was implemented very quickly in order to implement triage and remote consulting. So just to remind you, prior to the pandemic, probably 20% or so of practices were using some form of digital or clinician-based triage system in a comprehensive way. Within 2 or 3 weeks of the start of the pandemic, 100% of practices were doing that. And prior to the start of the pandemic, around about 80% of consultations in general practice were face-to-face and 10-minute consultations booked in advance by the patient. Within 2 or 3 weeks, that was down to only 10%. Now that 10% shifted fairly rapidly. By June, July time, it was up to 30%. Now it's up to around about 55% of consultations are face-to-face. But those shifts in the way that general practice is delivered, dramatic shifts, were embraced by general practice in the most remarkable of ways. People talk, I think probably rightly, that general practice services were essentially redesigned in a 2 to 3 week period, something that might have taken 2 to 3 decades if it had happened at time of peace rather than at time of war. So really a dramatic change. We also saw other use of technology in order to reduce the risk of spreading infection. We saw increasing remote monitoring of patients, particularly patients who might be sick with COVID, but also people who've got long-term conditions. So general practice was increasingly receiving data from patients relating to their blood pressure or their glucose control or their pulse rates or their oxygen saturations in order for us to be able to make decisions to manage their clinical care without seeing them face to face. And we also saw increasing use of technology for outpatient appointments. Although a lot of hospital services were shut down, those that were necessary were mostly carried out either on the telephone or on video, often three-way consultations between patients, consultants and GPs, which is really exciting, a really good way of providing care and a really good way of learning as well. Now, how did patients respond to those dramatic changes? I think initially, okay, they understood it was a crisis. The numbers of consultations dropped down pretty dramatically and pretty rapidly. Patients were worried about catching infections if they came into health facilities. They wanted to protect the NHS. That was the big message from the centre. And often a lot of patients thought that general practice was closed because the front door was closed, even though the service was still running, as Helen described in her introduction. So initially, I think patients understood it, but quite quickly became a bit fed up. They liked the old model of general practice in many cases. Of course, there are many people who like the convenience of remote access, but a lot of people wanted the service that they were used to. And that has caused and continues to cause some frustration for patients and some frustration for practices as well, particularly with the mixed messages that have come from the centre about whether we should be back to normal clinical practice, open access, face-to-face appointments, open access into buildings, or whether we're still in a pandemic. And I think there's been some kind of mixed messages there which have been unhelpful. How did clinicians respond? Well, again, positively initially. There's nothing general practice likes more than a bit of a challenge. It likes rising to those challenges. I think they embraced new ways of working remarkably quickly, and that was helped by significant investment in technology from the centre, something that we've been asking for as a college for a long period of time. It happened quickly because of the crisis. And also a significant removing of bureaucracy. It was really easy to get stuff done. It's one thing GPs hate, it's bureaucracy. So it felt like an interesting environment to work in and to innovate in, which was great. I think most practices felt kind of good about the reduction in workload. We saw at the height of the crisis a 24% reduction in number of consultations and a 28% reduction in time spent on clinical administration. In that respect, it felt good. And I've got a number of colleagues who said, general practice felt like a doable job for the first time in nearly a decade. But at the same time, we felt pretty worried about those patients that weren't coming forward. And we've got evidence now that there were patients potentially with symptoms of cancer that weren't coming forward. So there was a kind of a balance there. But of course, our workload went back to normal pretty quickly. By July, August time, figures were pretty much where they were. By September, we were seeing increased numbers of consultations. And right now, if you compare the first month, the month of May, with an equivalent period in 2019, before the pandemic, numbers of consultations are up by about 10%. time spent on clinical administration is up by nearly 30%. So things return to quickly back to normal very quickly. Still on, just lost a picture of myself. Is that okay? Yep, I'm back. Okay. It wasn't clear what form of PPE should be used in general practice. I think there were some GPs who wanted top-ranking PPE, the kind of stuff that you saw people in acute situations in hospital. There are others that recognised that it was a lower risk environment. What was settled on was gloves, mask, and disposable apron were the main forms of PPE. Early on, we were using separate examination rooms for the small number of patients we were seeing face to face. The PPE wearing, most general practices are still using right now because we're still in an infectious stage. Separate examination rooms aren't possible anymore because we're at a much higher proportion of face-to-face consultation. Social distancing is a real challenge in general practice. We know from surveys of our members, about 63% of premises are inadequate for the purposes, and that creates a real problem in terms of social distancing. And that's one of the reasons why front doors were locked, even though that was disturbing for patients and didn't always present the right image to patients as well. And a lot of patients have asked, if pubs are open, if supermarkets are open, why can't general practice be open? The answer is obvious. We're dealing with more vulnerable people and we're operating in a different setting. Then the vaccination program is the next issue that we had to deal with, clearly fundamentally important. What an amazing success for British science, amazing success for the government, amazing success for the NHS, and particularly amazing success for general practice, where consistently throughout the period that we've been operating since December, January this year, 3/4 of all vaccinations have been delivered from general practice and primary care based vaccination centres. That's probably going to start dropping now. We're with the younger age group. More people are going to mass vaccination centres, but that figure of 75% is remarkable. I remember having a conversation with Simon Stevens around September, October last year, and we were discussing what proportion of the vaccination program would be delivered in general practice rather than mass vaccination centres or hospital vaccination centres. And he said he thought 20%. I said I thought it would be closer to 80%, and we were right. And that's because general practice has got a track record of delivering mass vaccination programs, particularly with flu and childhood vaccination centres. It's because we're local, and it's because we have trust. And for a new vaccination where inevitably there are public concerns, public doubts, having trust in your local practice to do what we've always done around vaccinations was a really important part of the success of the programme. What we're seeing now is general practice is starting to withdraw from the programme, mostly because of the workload challenges that we have in general practice. Practices are saying we've got to get back to business as usual. So they're withdrawing, which probably doesn't matter too much at the moment because, as I say, younger people are going to mass vac centres. But when we get into the likely booster campaign come September, October time, it's probably very important that general practice comes back in again in order to maintain the very high vaccination rates that we see, much higher than anything that's been achieved in other countries. It's something we should be very proud of. So if I were to summarise what's changed in general practice as a consequence of the pandemic, it's probably as follows. So the first thing is greater use of technology, and I've discussed much of that technology for triage, for consulting, for monitoring, and for specialist advice. It's increasingly clear that technology adds an awful lot to general practice. It adds a new route of access for our patients. Some patients really like it, some patients don't. It's not going to go away. It's going to remain important. But it's also started a new conversation, I think, about where face-to-face consultations are important and do add value in general practice. And that's more than just the need for an examination or the need to do a blood test or a procedure or whatever. It's also about picking up soft signs, the number of times in general practice where being in the same room as somebody, seeing that they're disheveled when usually they're smartly dressed, smelling alcohol on their breath, seeing that they're really anxious. Those are important soft signs that I pick up, which help me to make a more effective diagnosis and a more effective treatment plan. And I think the issue of face-to-face consultations and relationship-based care, we know relationships, trusting relationships between patients and their clinicians are really important. I think there's been a new set of conversations about that, which has been important for general practice and important for patients as well. In addition to the greater use of tech, we've seen some interesting challenges around a shift in the way that general practices function. So traditionally we described three models of general practice. We've got a disease-based or biomedical model. We've got a psychosocial model, which is very much the kind of holistic model that general practice works to. And then we've got the public health model, the model that suggests that general practice has a role to play in improving the health of populations and the health of communities. And that third model, I think, has probably been the one which has been of least interest and least actioned by general practice over the years, but that's shifting as a consequence of the pandemic. And increasingly we're seeing GPs who are getting very interested in population health planning, in needs assessment, in exploring social determinants of health and social interventions, in exploring health inequalities, in looking at the assets that exist in their communities. And I suspect that as a consequence of the pandemic, we're going to see a much stronger focus for general practice on improving the health of their local communities, which of course will be helped by primary care networks and by integrated care systems and integrated care partnerships than perhaps we've seen in the past. And then the pandemic has also shone a light on a long-term challenge for general practice, a long-term crisis, I'd say, in general practice, which is undoable workload, and I've referred to that already. Massive workforce challenges. The problem is essentially a simple one. There's lots of things we can do about undoable workload. The most important one is increase the size of the workforce. We have got a demand that can't be met with the supply of health professionals working, and by that I mean both GPs and a whole range of different other health professionals, including nurses, physician associates, pharmacists, physios, mental health practitioners, link workers, a whole range of different professionals. We need more people, and I think that the COVID pandemic has shone a light on that, given people a taste for reduced workload, although, as I say, not always for appropriate reasons, and it's really important that we address that in the future. Which of the changes that we've seen in general practice will endure? I think to a greater or lesser extent, all of them will actually. General practice isn't going to go back to how it was. We will use technology more in the future. We will be more sensitive to our role around infection control than I think perhaps we have been in the past. So general practice will change, but I think it's important that we don't throw the baby out with the bathwater. The traditional model of general practice, i.e. local practices serving local communities, based on relationships, based on trust, based on continuity of care, based on comprehensive frontline, first line treatment, that model is not broken. It's a good model as long as it's properly resourced and made to work well. It can be enabled with better technology, it can be provided in different ways, but fundamentally we need to remember that the British model of general practice still remains something that we should be proud of and other countries are envious of. So as we shift into integrated care systems, it's important that the model of general practice is boosted and allowed to deliver its function to the rest of the NHS, taking the load off the rest of the NHS and making sure that we use the medical model appropriately. So lots of challenges through the pandemic for general practice and lots of things that we've learned and some, I think, an exciting future as well. So Helen, I hope that's helpful.
That's really helpful, Martin. And, you know, I was really fascinated to hear the way you talked about how general practice services had changed so dramatically in 2 to 3 weeks, changes that would have probably traditionally taken more like 2 to 3 decades. I'm sure you must be very proud of your teams. It was great to have you with us today, Martin. I mean, GPs and their staff really have done a wonderful job coping with the unprecedented times we've faced. So great to hear an insight into what general practices have taken away from the pandemic and how they might hang on to some of the old things from the past, but embrace new things too. So let's take a lunch break, a chance to relax and debrief. And remember, alongside grabbing something to eat, we'll have all of our platforms features open and available to you. So jump into the meeting hub if you haven't already done so, and continue to grow those connections with your fellow delegates, or chat further to those you've already connected with. And remember, this platform has been built not just as a means to an end for our events delivery, but as a unique, ever-growing community. The connections you build today will remain there for you to use into the future, logging in at your leisure and connecting with not just the delegates here today, but future registrants too. Our great speakers can offer you plenty of insight, but the most significant source of knowledge on our platform is you, each and every one of you. So feel free to share your experiences. Our digital marketplace is available too. Connecting with your fellow delegates and engaging with our partners are just some of the ways to earn points towards the gamification leaderboard. Come the end of today, those in first, second and third place will have a prize, which can either be Amazon vouchers, a donation to a charity of choice, or the planting, which I think is really cool, of an equivalent number of trees. That's the one I'd go for. Thank you, everyone, and I'll see you back after the break. Let's meet back at 2 o'clock for our next panel discussion. So see you then.